Good evening, everyone, and thank you for joining us for tonight's Woo You event with the one and only Dr. Justin Schweitzer. And he is going to be discussing diagnosing and treating neurotrophic keratitis. So you can go to the next slide. I'll be your host tonight. My name is Dr. Ariel Sorenzi. And this will be worth 1 hour of CE credit. So please be sure to attend for a minimum of 50 minutes. For your COPE certificate, please fill out the survey link that is in the chat, and it'll also be there when the webinar ends. CE certificates will be delivered via email and sent to ARBO with your OE tracker numbers, but we'll also have a QR code at the end of this presentation that you can use your OE tracker app to scan and get instant credit. Otherwise, those certificates will be emailed within about 4 weeks. We'll save questions towards the end of the presentation, and you can ask those either in the chat section at the bottom or the Q&A. If you're on your phone, you can find the Q&A either at the top or the chat feature under the 3 dots under More button at the bottom. So I'm so excited to introduce our speaker for tonight. Dr. Justin Schweitzer specializes in advanced glaucoma, refractive, surgical, clinical care, and anterior segment pathology at Vance Thompson Vision in Sioux Falls, South Dakota. He earned his doctorate of optometry from Pacific University and completed a fellowship with the American Academy of Optometry and now serves as optometric externship director at Vance Thompson Vision. He's a chief medical editor for Modern Optometry, a board member for the Optometric Glaucoma Society, and a frequent contributor to national publications. Dr. Schweitzer has lectured extensively across the country, including, I think, more Woo You presentations than any other speaker that we've had. I'm just gonna say that because I think it's true. So very passionate about all the things that he speaks on, and we really love having him on Woo You, and we look forward to hearing from you again. So I will have you take it from here. We'll
Thank
just show
you.
your financial disclosures, all of which have been mitigated, and have you take it away.
Thank you so much. Always an honor to be able to join you, Ariel, and the Woo U team. It's such a enjoyable, seamless process, and excited again to be able to be here and spend the next hour with everyone. We're gonna talk a little bit about neurotrophic keratitis tonight, and the nice thing about this type of condition is you probably won't see it a lot in your clinic. It's really classified as a rare disease, but the goal tonight is to not make you feel like you're missing the condition or make you feel like, boy, I'm not managing it in the right way. No, the real reason to have this talk tonight is to talk about what's new in managing and diagnosing this condition, because I will tell you flat out, this condition has snuck by me many, many times. Quite often, it's a patient that comes in that has what you think is ocular surface disease, slam dunk dry eye, and you're treating it. They're maybe not getting better, and you're trying a bunch of different things. And the reason they're not getting better is because it's really not dry eye. Dry eye may have been the underlying cause to force them into that state of NK, but neurotrophic keratitis is the problem. And so, really, my goal tonight over the next 50 minutes or so is just to raise some awareness around it and what are the different treatment options available. And I really have about 3 cases that are scattered throughout this lecture. You can see the one right in front of you already that we'll talk through. And I hope by the end that you'll feel comfortable, one, diagnosing, knowing your different stages of neurotrophic keratitis. Number 2, being able to do some corneal sensitivity testing. 3, think about, what is the history? What are the things that lead to neurotrophic keratitis? Because I will tell you, when we get to the history portion of this, I've never diagnosed a patient that doesn't have certain pieces of ocular history or systemic history that we find in the chart. And so that's a real key indicator of driving you to that diagnosis. And as I said before, it's okay if you miss it the first time. It's when that patient comes back and you need to catch it the second time. And especially with stage 1, for example, always a challenging thing to pick up. Stage 2 and 3, a little bit different. So excited to spend some time with you tonight. Please ask questions. We'll handle those at the end, and let's jump right into it. So this was a 69-year-old patient that was sent in to see me, complaining of his vision getting progressively worse, more so in the left eye than the right eye, complaining of fluctuating vision, which seemed to be worse in the evening. Fits right with dry eye, right? Fluctuating vision. That's what we see with our ocular surface disease, our dry eye patients. We can see worsening of vision as well. So again, the history there, the first part of it, what he's telling me, yeah, you have dry eye, sir. That's the first thing you think about. And then you dive into a little bit of his ocular history and what he's taking for medications, and of course the ocular exam here in a second. But you can see his visual acuity, 2025 in the right eye, 2200 in the left eye. Boy, 2200 is concerning. Not often do I see a dry patient with 2200, every once in a while, but we need to figure out, are there other things obviously going on? Is there a cataract present? Well, he's already had cataract surgery. Could it be a retinal complication? We need to take a look at the retina to make sure. And then obviously we're going to look at the front surface as well. We look at his ocular history. Boy, he's had a lot that's been done to his eyes. He's had blepharoplasties. He's had cataract surgery. He has glaucoma, so he's had some MIGS procedures. He's got a history of exposure keratopathy as well as Bell's palsy that caused that exposure keratopathy in the left eye. And then you look at his ocular medications. He's on 2 glaucoma medications to control his intraocular pressure. He's doing well there from a glaucoma standpoint, but could those medications be contributing? And that's another thing as we go through these different cases is all the different comorbidities that come along with neurotrophic keratitis, all the other things that can contribute to maybe accelerate it or make it worse or cause it to become more progressive. Topical medications with preservatives, especially if they've been on a long term, come into play. And so already in this situation, we're thinking about how am I going to manage this patient's glaucoma, but what's going on with this 2200 vision in his left eye? And keep in mind, just to tell you right now, we're not going to get into looking at his visual fields or those types of things. This is a fairly mild glaucoma patient, so he's actually doing fairly well. Now he's on multiple medications, but he's got no significant visual field loss contributing to a vision loss here. You're going to see here, I'll talk about his, back of the eye fundus findings, which were essentially normal. So those things, though, you have to rule out. We look at his systemic medications there, and then you take a look in the slit lamp. And so this is what you're seeing, kind of that centralized PEE or SPK coalescing together right over his visual axis. And this is his left eye. His right eye was similar, but much less. His right eye had much less of this, some of it there, but a distinct difference between the two eyes as we look at that. Here's some other considerations too that made me think, all right, I need to approach this a bit differently. He'd been on multiple other ocular medications that the referring doctor had done a wonderful job of trying to treat and make this PESPK get better. Multiple immunomodulators twice a day, preservative-free artificial tears, topical steroids. So some other treatment options that were considered. And so when I have a patient like this in my chair, when I know that, hey, the visual field looks okay, the back of the eye looks okay, which you'll see here in a second was just fine. I see something like this on the surface of the eye, and a heroic effort was made to try to make the surface better, but it's not getting better. And the patient really isn't complaining of something like pain, which I will ask these patients. That immediately makes me start to think of, neurotrophic keratitis. Because this doctor tried, right? You can see there's a lot of good treatment considerations here to try to improve this ocular surface. And so I went ahead and did corneal sensitivity testing. We're going to dive into that here in a little bit. This is just to set the table. And this patient really had no sensitivity in all quadrants. I knew it right away when I tested his central quadrant. I probably didn't need to test other quadrants. He had no sensitivity. Intraocular pressure, as I mentioned, well controlled. Posterior segment in the left eye looked great. No macular problems. And so the majority of the visual problem here coming from that window front part of the eye. So now we have to ask ourselves, what are we going to do for this patient? What are some considerations? What do we want to think about in order to try to maximize or improve that visual visual acuity, but also the ocular surface? Keep in mind that immunomodulators have been tried. They tried a topical corticosteroid. When I see staining like this, the first thing that my mind thinks of is there's inflammation present. And so I also probably would have considered either an immunomodulator or doing a topical corticosteroid. Both of those things didn't seem to improve this patient's clinical situation. Preservative artificial tears didn't help this patient. And so for me, I get fairly aggressive with these patients. And so I diagnosed stage 1 neurotrophic keratitis. We'll go through the staging here in a few minutes. I inserted a punctal plug. I think that punctal plugs at times get underutilized, and I think they can be a very powerful agent in helping us to treat ocular surface conditions. We're trying to keep more tears in the eye. I did still start a topical steroid because to me, I can't get it out of my system. I see staining. There's got to be some inflammation present. And then a key thing for me is removing some of the agents that may be damaging the surface. Yes, we're risking, the pressure increasing a bit by stopping those topical glaucoma medications in the left eye. But for me, if I'm going to leave them off a topical glaucoma medication for a month, the chances of a patient with mild glaucoma with a pressure of 11, is I believe what it was, is pretty low that they're going to get significantly worse on me. And so I'm very comfortable stopping that glaucoma medication for even a month or two to be able to try to improve the ocular surface. And then for this patient, I went ahead and used a cryopreserved amniotic membrane graft. Now, there's a lot of different other considerations here that you could do for this patient, and we'll touch on that. But to me, this in stage one, using technologies that hadn't been done previously by the other doctor that sent this patient in for me, I'm hoping I can get some improvement here by getting the preservative off the eye, trying to calm down the inflammation, and then that amniotic membrane graft healing along with increasing the tear film as much as possible. There's a lot of other considerations. We're going to go through all of these tonight, and I'll show you the end of this case here in a second. When we think of the wheelhouse of optometry, what can we use? We can use almost all of these. Now, we get into surgical intervention on the right. That's more for ophthalmologists. That's in the ophthalmology world. But our goal as optometrists, if we encounter a patient like this, we want to use the stuff on the left. We want to use topicals and in-office procedures to be able to help these patients. So hopefully we don't have to send this patient to have some type of surgical intervention. And I really believe that everyone on this lecture tonight can utilize these topical or in-office procedures to manage any stage of NK. And hopefully tonight you'll be empowered to do that. When we think about the topical agents on the left, obviously artificial tears probably aren't going to be enough for a lot of these patients, but there's still a nice adjunctive piece that we need to think about. I talked about inflammation and corticosteroids. We'll talk tonight about autologous serum and PRP. In certain stages, we have to worry about infections on top of is it NK, so antibiotics. We're going to talk a little bit about synendromin tonight, which is an FDA-approved treatment for NK. There's experimental stuff being done with topical insulin as well, and then immunomodulators. Those in-office procedures, nothing here that any of us really can't do. We can place bandage contact lenses. We talked about punctal occlusion. You can do tape tasarrufes, where you take a piece of tape and you actually have the patient, especially at night is when I like to utilize this, and tape the upper lid closed for them essentially, teach them how to do that so that they don't blink at night or there's not some exposure at night. So those tape tasarrufes, amniotic membrane grafts, I'll show you a video of that here in a little bit, and then tissue adhesives as well. And then we get into those surgical interventions, which we're trying to avoid, but at times are needed, especially when we get to stage 3 types of NK. So this was the 10-day follow-up for my patient. And so they came back. You can see a significant improvement in the visual acuity. We're going to remove that amniotic membrane graft ring, being this is a cryopreserved. That topical corticosteroid, I'm going to go ahead and taper that down. But you can see not 100% healed, but significant improvement. The window of the eye looks much better. The visual acuity is much better. We're moving in the right direction. And then I would challenge you too to think about what are your glaucoma treatment considerations for this patient. So you now are moving them in the right direction. You now are getting them to a better spot. You look at that cornea, it looks much clearer. Their vision's much better. Do we add both topical glaucoma medications back now? And I would argue no. I would start to think a little bit outside the box. What can you do to treat this patient? We now have implantable devices to lower intraocular pressure, drug delivery. Maybe not a long-term solution, but maybe a 1-year, 2-year, even 3-year solution for a patient like this. Do we think about doing something like a laser? Is SLT an option for this patient? With mild glaucoma, I would argue it probably is. And could we reduce their medication dependence there? Preservative-free glaucoma medications as well, just trying to minimize the preservative on the eye. Don't reverse what you've just healed. You've made this patient significantly better just by the image that you're seeing there, their visual acuity. By putting that preservative back on the eye, let's not reverse what we've done. And so for me now, I'm thinking maintenance. So removing that amniotic membrane graft ring. We're going to taper that steroid, and then I'll get them off of that. And then to continue to control inflammation, I'm going to use an immunomodulator twice a day to manage that cornea, and then think outside the box a little bit on what's my glaucoma treatment consideration. Maybe an implantable device, probably consider SLT to try to minimize some of that drop burden. So that case is kind of just to get us ready as we talk a little bit about NK. And those are cases that you're going to encounter in your practice, especially if you're managing a lot of glaucoma. You'll see some of the other history stuff here in a little bit. If you're managing patients that have these types of history, they're going to walk in your door. Remember what NK is. It's a dysfunction of corneal innervation. At the hallmark of what neurotrophic keratitis is it's a loss of corneal sensation. The homeostasis, the discussion between the epithelial cells and the nerve growth factor that's in our cornea, there's a breakdown. They're not talking anymore. And so this beautiful loop where you have the corneal nerves providing protective and trophic functions to the corneal epithelial cells, this loop breaks down. There's a breakdown in that loop. And it can happen for a variety of different reasons. Sometimes it's because the nerves are actually damaged from something like a reoccurring herpetic simplex virus or a Zoster's virus in the cornea. Sometimes it's from chronic dry eye over years and years and years. And so the corneal epithelial cells have been broken down over and over and over again. And no longer can they survive or provide information to the corneal nerves. And then the corneal nerves are not able to provide information to the corneal epithelial cells. And so our goal is to keep this communication occurring. Keep in mind, too, that neurotrophic keratitis, much like glaucoma, is the way I think of it, is it's a progressive condition. And so if you have patients that have stage 1 NK, they may stay at stage 1 NK for years and years and years, but eventually they're going to go ahead and progress. They're going to move into stage 2. And if stage 2 isn't treated, they're eventually going to move into stage 3. And the other hallmark with these patients, as many of you know, and I'm just providing information and repeating this, is they don't have pain. These patients don't have pain, so they're not necessarily going to be coming in like a patient that has a corneal ulcer, for example, that's in a ton of pain. They may come in when they've had it for an extended period of time and they're just finally frustrated with the way that they're seen, or they're frustrated that certain treatment options just aren't working anymore. And so just have it in the back of your mind that patients that have failed with multiple medications aren't in pain, but the cornea looks terrible, looks mushy, looks beat up, that could be an early indicator of neurotrophic keratitis, and you'll need the corneal sensitivity test. And we'll talk about that here very, very soon. So here's the diagnosis of NK. The clinical history is extremely important. You'll hear me probably say this multiple times tonight. We'll look at the clinical history in a second. I'll give you a list of that. But I've never diagnosed a patient with neurotrophic keratitis that does not have something in that list that I'm going to show you here in a little bit. And so just paying attention to that patient that comes in, and I look through that clinical history and I say, no, they've never been on glaucoma medications. They've never had any ocular surgery. They've never had a herpetic condition. They're not diabetic, so on and so forth. It's probably not NK. But if they're a patient that has diabetes that's not well controlled, or they've had a herpetic infection, they've had a chemical burn, they have multiple sclerosis, they have glaucoma medications, then NK is in the back of my mind for these ocular surface disease patients. You see a persistent epithelial defect or an ulcer, it's on your mind if the patient is not in any pain. And then the hallmark is that decreased corneal sensitivity. And so testing that very quickly in your clinic, and again, we'll touch on that, is something that really will help you make that diagnosis. I briefly want to pause here and just touch on, a quick dry evaluation comment. I think at times, we sit in on dry eye lectures. I give dry eye lectures. I sit in on ones of them. And I think it's important to be detailed. And, we think about dry, it's become complicated. But I will try to empower you guys to think of dry eye at times as a little more simplistic as we're diagnosing it. I'm a believer that technology is great, and we have a lot of technology at our practice. But for some of you, maybe you're just getting started and you're like, boy, I don't know if I can treat dry or I can manage dry because I don't have all the technology. But I'll empower you again tonight that you can. Really, you need, in my opinion, 4 things. You need to start with some type of questionnaire. It doesn't have to be a speed questionnaire. Recently, TFOS DUES 3 came out, and the OSDI 6 was one of the surveys that was mentioned there as an option. And it's 6 quick questions for your patient. It drives the conversation. You need a slit lamp. I hope everyone that's an optometrist on this call tonight or an eye care provider has a slit lamp. I think we probably all do. Vital dyes. Vital dyes, crucial, easy, inexpensive. You can find out so much with vital dyes. You can find staining out. You can look at the tear meniscus. You can look at tear breakup time. There's so many things that you can find here, conjunctival staining. So just having those vital dyes, and then you need one digit. You only need one, and that helps you to evaluate the glands. Now, I'm a fan of looking at the anatomy of the glands, so my biography is excellent to have, but pushing on the glands alone to be able to look at what substance comes out of those glands can be extremely helpful in determining, all right, we have a meibomian gland dysfunction piece here. And if you have these 4 things, you can treat a lot of dry and you can treat it at a high level. And then once you become passionate about it and your practice continues to build, then you'll invest in some of these other types of technologies, which is osmolarity, which is a great technology to tell you that the homeostasis, the balance of the tear film isn't accurate. Meibography to be able to look at the structure of the glands, and then even inflammatory types of technologies. And I had a little acronym down here, and this comes from the ASCRS, and then I added an extra one to this. All we have to do is we need to look. We lift that lid, you pull on the lid a little bit, you push on it, and then have your patients look down. We're looking for things like Demodex blepharitis, traditional blepharitis, because we definitely have to manage that as well. And what comes along with all of this is a lot of times you'll treat dry eye and maybe the patient isn't getting better. And that will lead you to say, all right, I need to consider neurotrophic keratitis here. We even have technologies, as you can see here, that can do, in 2 to 3 seconds, a battery of different things like non-invasive tear breakup time, eye blink, lipid layer thickness, tear meniscus height, meibomian gland loss. So you actually get a meibographer with this. And so definitely things that you can utilize, not overly expensive technology that you can implement to really manage dry eye at a high level. So here's the list. This is the list that I was talking about. I have never diagnosed a patient with neurotrophic keratitis that hasn't had something on this particular list, whether it's HSV, whether it's a zoster, obviously anything that's affecting the trigeminal nerve, because that is really what's innervating the eye. Damage to those corneal nerves is the hallmark of NK. We think about topical medications, overuse of those, so topical glaucoma medications, surgeries of the eye. This list here, extremely important, because to me, I doubt you're going to diagnose NK if one of these things isn't in that patient's history. This is looking at the prevalence and the risk. And again, you'll see a lot of those etiologies fall within here. In your guys' practices and in my practice, you could see that this probably resonates with you. The 4 most common types of patients that are diagnosed with NK, number 1, diabetes. And this is in no particular order, by the way, so I shouldn't say number 1 is diabetes. These are just the top 4, but diabetes is in that top 4. HSV keratitis, patients that have suffered from it one time or reoccurring are very at risk for neurotrophic keratitis. Any type of patient that's had LASIK, PRK, previous refractive surgery, and then patients with glaucoma, mainly because of the topical agents that are being utilized, they're at more risk for neurotrophic keratitis. We'll try to keep these in your mind, and I've provided handouts as well, so you should have this list of these types of etiologies in front of you. If you don't, we'll be able to provide that to you. This is extremely important, the classification, and why it's important is if you ultimately decide you're going to prescribe now the new FDA-approved medication, it's actually been around since about 2018 or 19, you have to stage your neurotrophic keratitis, and you want to be accurate with your diagnoses as well. So the Mackey classification is a classification system we typically use clinically to class neurotrophic keratitis. So stage 1 would be what we just saw, your persistent epithelial or SPK. It's going to look a lot like dry eye. And I told you earlier, I guarantee you that you will, and I've done it many times, you'll diagnose a patient with ocular surface disease, dry eye, because it's actually stage 1 NK. They look similar to one another. It looks like SPK, PEE, there's inflammation present is what we're thinking about. That's stage 1. Stage 2 is a persistent epithelial defect. Looks bad. The key is there's no stromal involvement, and the other key factor is there's no pain. the patient isn't complaining about it. And you'll see a case of that here in a few minutes. And you're going to say, how can that patient not be in pain? That's exactly it. That's the really defining factors. You're going to look at that eye and say, boy, that's ugly, but there's no pain. I need to be thinking about NK. And then stage 3 is really stromal involvement. We're getting into the corneal ulcers, the melting, the perforation. This is the stuff we're trying to avoid. This is the bad stuff. This is the really, really tough stuff. The majority of patients that I see that come into my practice, honestly, are stage 1 and stage 2. I do see a few stage 3 off and on, but stage 1 and stage 2 are definitely more common for me. And again, as I mentioned earlier, progressive in nature, so they will progress over time if it's not diagnosed. Corneal assessment, really the only way to technically diagnose. Another very important thing to put in your chart note. So 2 very important things. 1, the classification, and number 2, the corneal assessment. And this doesn't have to be complicated. In my practice, I just use a wisp of cotton. That's all I use. You can use dental floss. They do make actually automated technologies now. There's a company that makes an automated technology where you can get quantitative data on sensitivity. There's Cochet-Bonnet, which you can use as well. For me, very simply, I use a cotton wisp. I typically just test the central part of the cornea. And if I don't get what I want out of that central part of the cornea, I'll test other quadrants. My other advice to you would be, if you think it's unilateral, always test the eye that you don't think is involved. So I'll say that again. If you think it's unilateral, always test the eye that you don't think is the problem. The reason that I do that is, 1, I kind of want the patient to feel it. I want them to know I'm doing something, and I want to see their reaction. And so the eye that has sensitivity, I'll just barely touch it with that cotton wisp, and they'll jump out of the chair, or they'll back up, or they'll tell me to leave them alone, right? And then you can go to the eye that has no sensitivity or minimal sensitivity. You're testing it, you're trying to find out, and do it in that eye. And number 1, it's reinforcing to the patient, because I'll say to them, did you notice the difference? And they know there's a problem. And that gets them to buy in to the treatment, hopefully, that we're going to talk about. But also, if they don't really tell you they can tell a difference, I'm able to look at the reaction. I can see the reaction of the way that they act. Now, for some patients, it's going to be bilateral, like our first patient that we just looked at. Patients that have diabetes or that are taking glaucoma medications in both eyes, you may have some difference in sensitivity. And so in that situation, you have to use your clinical judgment. You're going to put that wisp on the eye. If you're able to rake that cotton wisp back and forth across their cornea and they're not moving or flinching, there's no sensitivity present. In my chart, I really just document 3 things. I document no sensitivity, I document full sensitivity, or I document reduced sensitivity. And so those are my 3 different chart notes. So no sensitivity, complete sensitivity or full sensitivity, and reduced sensitivity. That way I have 3 easy things to put in the chart, and then I document the stage. By doing that, it'll assist you in hopefully getting certain treatments that you want for your patient. And again, just having a very thorough record for these types of patients with NK. These would be characteristics to prompt you to do corneal sensitivity testing. And again, I'll tell you, there's times where you're going to initially treat the patient like it's a epithelial defect, or you're treating a patient that has ocular surface disease. Don't beat yourself up over that. It happens all the time. The key is that when they're not getting better, you start to think down that other avenue, which could be NK. So you can see the strongly recommended situations here from the literature that would say this would be a reason to corneal sensitivity test my patient. On the other side here would be some maybe considered type of situations. One thing you'll run into is you'll have a patient in the chair that you may have already put Proparacaine in the eye. And then you figure out, boy, I need to sensitivity test them. Those are patients you have to bring back. You're going to see in one of my cases here in a little bit, they were in for a cataract evaluation, and we'd already worked them up and they were dilated, and something didn't smell right. And I'm like, something's off here with this patient. And we had to bring them back to do sensitivity testing. We did the whole cataract workup, but they needed sensitivity testing, so we had to bring them back. That is going to happen to you. Nothing wrong with that at all. Amniotic membrane grafts can be very helpful in treating our patients with NK. And I will tell you, almost all patients with NK do get an amniotic membrane graft. mainly because I think it can at least start the process of healing. There's a variety of different types that you may use. Cryopreserved or one type that you can utilize. There's a variety of different those out there. Dry membranes would be the other option. With dry membranes, you do have to place a bandage contact lens over the top of that. But I am a strong advocate for amniotic membranes, especially in the setting of neurotrophic keratitis. These would be the different advantages of them. Many of you are familiar with this. We know that amniotic membrane grafts promote healing. They're a fast, simple surgical procedure that all of us can do in our exam lanes, and many of you are very proficient at this. There's data around NK. You're going to see a study here in a minute that shows that cryopreserved or amniotic membranes can help with neurotrophic keratitis. We think about disadvantages. They don't work all the time, and that's the case with NK. They don't always work. VA is not always preserved. We know when we put these on the eye, if the patient's already seeing pretty good, we're going to make their vision a lot worse. My patient earlier, 2200 vision, not too concerned about making them a lot worse in that situation, just trying to heal the surface. So advantages and disadvantages of these things. Here's some studies. They're older studies in regards to amniotic membrane grafts in regards to neurotrophic keratitis and small studies. Again, neurotrophic keratitis more still classified as a rare disease. So we have to take into account that this is a smaller number. But what's impressive is the healing rates in both these particular studies where we saw, 100% healing in both the 1999 study and the 2011 study using these amniotic membrane grafts to heal these patients. So I'll take you through a quick video of how to place one of these. We all do it a little bit differently. I'll provide you kind of with my tactics, the way that I like to do it. And so I do typically glove up when I'm doing this. And you'll see here, this is a cryopreserved amniotic membrane graft. We're peeling it back here in a second. And then I have some BSS sitting there on the table as well. Any type of sterile saline would work fine. You just want to rinse the amniotic membrane graft off gently before you place it on the patient's eye. This particular patient had a stage 3 neurotrophic ulcer. And so a very advanced type of patient. Some doctors like to just use their index finger and their thumb to be able to kind of squeeze the amniotic membrane graft and place it. Some like to use a forceps, as you'll see in this particular video. I will tell you, I've kind of navigated from at times, depending on the patient, where I'll use a forceps to times where I'll actually use my fingers to squeeze it like a taco and place it. Be a little bit careful. They're slippery. So if you kind of squeeze it like a taco, there's a chance you shoot it across the room and you're going to waste that graft. Also, a little bit embarrassing if you have externs or residents in the room with you or anyone observing, and a little embarrassing to the patient too if that amniotic membrane graft goes shooting by their ear. So we go ahead and you'll be able to tell. It's like a contact lens. You'll be able to tell what's inverted or not inverted. Very easy to know what side should go down onto the cornea and which side shouldn't. Again, this has a self-retaining ring, amniotic membrane graft in the middle. I'm just cleaning it off, rinsing it off before I place it. I always lay my patients back. And so this patient you can see is laying back in the chair. I have him look down. I get it underneath the upper lid first and shove it way up under there. I know it seems like, boy, that goes a long ways up there, but you have plenty of room up there, I promise you. Pull that lower lid down. Now I'll have the patient slowly look up, and you can see my finger towards the top of their upper lid, just trying to center that amniotic membrane graft. Once the procedure is done, I will now sit this patient up, get him behind the slit lamp, and I will gently adjust that ring to make sure it's centered as need be. And then I'll usually see these patients back 7 to 10 days later. And if that graft has dissolved, I'll take that retained ring out. If it has not dissolved, I'll try to leave it. I'll try to leave it for as long as possible to get all that healthy tissue to try to help heal the corneal surface. Let's talk a little bit about Synendramin, which is an FDA-approved drug. It's out there for NK. So for neurotrophic keratitis, it was approved in 2018 for children 2 years of age or older. And so this is a commitment. I will say that when you look at the data here in a little bit, though, I think you will be impressed. I know from a clinical standpoint, being able to use this now for an extended period of time, that being the only really FDA-approved treatment for NK, it's helped a ton of my patients. And the data supports it. And I challenge everyone, and I say this all the time, you have to believe in the data before you start prescribing things. I don't care if it's dry eye drops. I don't care if it is glaucoma drops, whatever it may be. Look at the data, believe in it. And then this is administered 6 times a day for 8 weeks. I'll talk a little bit about follow-up with this as well. But Synendromin, this is available to your patients with NK. There are some retrospective studies out there looking at Synendromin with stage 1 NK. We're going to get into talking about the FDA clinical trial here in a little bit, which was stage 2 and stage 3, but plenty of stage 1 type of NK studies out there as well. This was a small retrospective study of about 17 patients. These patients had to have at least stage 1, obviously with diffuse punctate epitheliopathy, and then they were unresponsive to other treatment options. I will fully admit with stage 1, quite often I don't start with Synendromin. As you saw with my first patient, with stage 1, I try to exhaust other options first. Not that I can't use it, it's just that a lot of times I feel in certain scenarios I can heal a stage 1 NK patient without this medication initially, have this in my back pocket. It's different for me with stage 2 and stage 3, as you'll see with the data here in a little bit. I typically go right to this medication for stage 2 and stage 3. You can see the causes of NK in this patient population, multifactorial, dry eye disease, herpes simplex. So a lot of these patients had diabetes, all the things that we saw with the etiology earlier. And then you look at some of the data in this particular study. You look at the baseline corneal fluorescein staining versus post-treatment, how much less it is, the improvement in that. So these patients went from a 4.0 down to a 1.06. To give you an idea of how this works, 5 quadrants on the cornea. The highest score you can get on a corneal and a quadrant is 3. And so 5 times 3 is 15. So the max score these patients could get would be a 15. So these patients came in on a 4. Going on Synendromin, they went down to a 1.0. And you can see their best corrected visual acuity went from 20/40 down to 20/30. You look at visual acuity as well. That was an improvement. And then what also is really interesting is in this study, they actually were able to image the nerves, which I think is fascinating, to show that there was some regeneration of the nerves. When we talk about Synendromin, it's really a copy of our nerve growth factor in our corneas. So it's a recombinant nerve growth factor type of medication. And so really it's designed to treat neurotrophic keratitis, of course, but can it heal the corneal nerves? And so when you look at this particular study, it's very interesting. They actually took images pre-treatment, post-treatment of what was happening to the corneal nerves. This is another study. This was called the Defendo study. This was a stage 1 study as well. These patients were placed on Synendromin 6 times a day for 8 weeks. By 8 weeks, you can see here kind of the data down in front of you. A high percentage of these patients getting corneal healing, actually having improved corneal sensitivity as well. We'll talk a little bit more about Synendromin here in a little bit when we get into the actual clinical FDA clinical trial data, the US trial, and there was a study done in Europe, the Reparo study, that helped to get this medication approved. Another case. So this was a patient that came in noticing a steady decline in vision in the right eye over the last few months. Really no pain present, just that decline in vision. 80 years old, visual acuity, as you can see, there was 20/70 in that eye. For the sake of time, I've left the left eye out. Left eye was unaffected here, but so we're focused on the right here. Patient does have glaucoma, again, very common in my clinic. So I see a lot of glaucoma, and so a lot of my NK patients are my glaucoma patients. Had cataract surgery, taking a glaucoma medication once a day. Intraocular pressure well controlled for this particular patient. And the posterior exam looked really good. Yes, there was some visual field loss. There was some retinal nerve fiber layer thinning, as well as an inferior notch. But nothing that was really causing a ton of decline. It wasn't anything centrally oriented. You look at the slit lamp exam. Do you think that patient should be in pain? I would say they should be in pain. You see a defect like that. To me, I'm like, well, why are they not complaining of pain? Immediately in your mind, you should go to this is possibly NK. I should at least corneal sensitivity test this patient. When I see that, there's got to be pain. We know from abrasions, we know when the epithelium is beat up that there should be discomfort for this patient. And so this was a stage 2 patient after I did corneal sensitivity testing, and that was absent in all quadrants. And we looked at our Mackey classification, right? This is a persistent epithelial defect, and a little unfair to you guys because you don't have a slit lamp here, and this was my patient, but there is no stromal involvement with this particular patient. This is all epithelial involvement, so that's why it's stage 2. As I mentioned earlier, for me, I plug a lot of these patients. I'm going to order Synendromin for this patient because it's stage 2, and I'll show you the data on why I did that here in a second. Moxifloxacin to cover the risk of a secondary infection. I don't want to get a bacterial infection in this patient. And then again, let's stop that glaucoma medication for a while. Let's try to get this healed. And then finally, for me, as you're going to find out here in a little bit when we talk about Synendromin, you won't get it immediately. You order this medication, it takes roughly a month to get it. And so I don't want to wait a month to start treating this patient. So almost all these patients, I place an amniotic membrane graft on their eye to kind of start the healing process, to get things rolling in the right direction until I can get the medication to start healing them as well. So this patient at 1 month, and I always see my patients back at about 4 weeks. Remember earlier, I mentioned that this medication is 6 times a day for 8 weeks. I see them back at 4 weeks for a couple of reasons. One, I want to make sure they're compliant. I think that's really important. Obviously, when you're dosing a medication 6 times a day, that's a big commitment to the patient. So I want to make sure they're compliant. But two, I like to celebrate with my patients because a lot of times these patients are doing better. You could see this patient isn't 100% healed yet, but that looks a lot better. Vision's better at 20/50, 2 lines better. I'll take images for patients, I'll show it to them, and we'll celebrate. We'll celebrate a little bit and say, hey, we're moving in the right direction. I think that's really important for the psyche of a lot of these patients to know that, hey, I'm getting better. What I'm doing matters. It's a big commitment. I'm taking this drop 6 times a day, but I'm getting better. Of course, the amniotic membrane graft had already come off at day 10 or so. We're going to continue this treatment to go ahead and get to that 8 weeks. And then I will see them back again, kind of at their 2-month follow-up or 8 weeks. And you can see the persistent epithelial defect here has now closed up. With that said, do I restart the bimatoprost? I did in this patient. Again, we want to consider that, should we or shouldn't we? And then we need to start something else. I chose to do an immunomodulator twice a day. I think there's a variety of other things you can do. The visual acuity is still only at 20/50. Patients in a much better spot. We're not 100% there. We still have a lot of work to do for this patient, but we've gotten past the point where at least we don't have that persistent epithelial defect. I will also say to you that I may wait a month or two, but if this patient is kind of stuck at 20/50 a month or two later, I have no problem going ahead and sensitivity testing them again and re-prescribing the Synendromin. No issue with that. From a safety standpoint, well-tolerated medication, no systemic concerns with it. If I'm not moving the needle for this patient, I'm willing to do that and prescribe that again. Real quickly, some of the pivotal trial data around this drug. These were all patients that had stage 2 and stage 3 neurotrophic keratitis. So there were no stage 1 patients in these clinical trials. The Reparo study was done in Europe. The US study was done obviously in the United States. You can see duration of follow-up was about 48 weeks in the Reparo study, 24 weeks in the United States trial. The real primary endpoint, which I think is a tough one, and it's very impressive to be honest with you when we think about this, is complete corneal healing. So you couldn't have a cornea that looked like that. Okay, that didn't work in these clinical trials. It had to be completely healed. And so when you look at the healing rate in the different clinical trials, on your left is the Reparo study. And you can see the healing rate with Synendromin at 4 weeks and 8 weeks at about 58% at 4 weeks, 72% of these patients at 8 weeks. And then the US study really following in suit with that at about 56% and then 65%. And so not all our patients, but we're seeing about 3/4 of the patients in the European study. We're seeing about 2/3 of the patients in the US study that were getting complete corneal healing. I think the other take home that we learned from the Reparo study is that out of that 72% of patients that were completely healed, 80% of those patients stay healed for out to a year. And so even though we only use it for 8 weeks, it appears that it can control these patients for a longer or extended period of time as well. This just looks at the adverse events. And so just talking to your patients about what they may be affected by so they can get some installation site pain. They can get some lacrimation, some hyperemia with it, low percentages. And one thing that I've learned, and this is a clinical pearl that I've learned over time utilizing Synendromin, is remember these patients when they come in really a lot of times have reduced sensitivity or no sensitivity. They start the medication and they have no problems. Then about 3 weeks in, 4 weeks in, sometimes it's 6 weeks in, they'll call my staff and they'll say, boy, the drop is really starting to bother me. And the reason it likely is starting to bother them is because we're getting some sensitivity back. And so it's not a bad thing, something to educate your staff on, to be aware of, that at times they will start to get some sensitivity back. Other considerations around treating NK. So a variety of different things to think about. Autologous serum drops, PRP drops, very successful as well in managing these types of patients. And I utilize them quite often for a variety of different conditions, ocular surface disease, obviously dry eye, but I also use it often in certain types of NK, especially stage 1 NK. You do have to work with a laboratory typically or have a compounding pharmacy near you. In our practice, we actually draw and produce these in-house. And then we usually produce about a 3-month supply for these patients. You remind them that it needs or requires some refrigeration. I typically start with 20%. The literature ranges from 20% to 50%. I like 20%, think it's very successful, does a nice job for these particular patients. There are some studies here. You'll see this in your handout as well. A retrospective study, yes, small, but again, we're dealing with more of a rare disease. And in that study, they did treat all stages of NK. So it was stage 1, stage 2, stage 3. It was with also 20% topical autologous serum. And the dosage, I'm usually fairly aggressive with it. Quite often, I'll do 6 to 8 times a day initially and then kind of work my way down. Want to get healing as quickly as possible. So don't discount autologous serum drops or PRP drops as an option. Scleral lenses, not a medication, right? But something that, if fit beautifully, can really help some of these patients. Remember, this isn't infectious in nature. And so I'm very comfortable, if I need to fit a scleral lens on some of these patients. Probably utilize this less than I did previously in my career, just because of the advent of, amniotic membrane grafts and having Synendromin, autologous serum drops. But these should not be discounted, and you should consider it. In the literature, there are studies that have been done looking at this as well. I do want to make a comment about a patient. You see that image there of that corneal ulcer. I didn't mention this earlier, but it's very important that, yes, the patient may not be in pain, and so you're pretty sure it's NK. You really want to make sure you rule out anything infectious. And so I would fault no one, and I do this often, to do a culture. To make sure that you're not dealing with something that's infectious in nature if you're not 100% sure it's NK. That would be a situation where maybe they have reduced sensitivity and they don't have complete absent sensitivity. Reduced sensitivity to me can make me a little bit nervous, especially if you see an ulcer that looks similar to that, where you're thinking, boy, is this infectious or is this NK? And so don't be shy about culturing those patients as well if you're concerned. Topical insulin, still considered experimental, but I think worth discussing in an NK lecture. We're still trying to understand it, but you can dilute insulin. You can see the low dosage there of insulin. This would be done at a compounding pharmacy. Technically, would be utilized as off-label, but again, as doctors, we're allowed to do things off-label. We're allowed to do things that we think are in the best interest of our patients. And so you can see some images here of a patient that had a pretty significant neurotrophic keratitis ulcer that was dosed with low dose insulin 6 times a day. And you could see the improvement, not a 100% healed, but some improvement for this patient. Again, some literature there, I've kind of cited it for you, still considered experimental, but you run into a situation where maybe you are unable to get Synendromin for a patient, whatever that may be. This may be a consideration as well. All right, last case here as we kind of wrap things up. This was a 68-year-old patient, came in for a routine cataract evaluation with me. I see these all the time, every week, these types of patients, type 2 diabetes, not overly well controlled, worsening of vision, comparing to some glare over the past few months. You look at the visual acuity, yeah, it's reduced, fits very closely to what I see with a patient that has cataracts. Glare tests down to 2100. Has a 2+ nuclear sclerotic cataract with some dry eye, MGD, along with SPK on corneal staining and an enormous fundus exam. I'm probably not going to move forward with cataract surgery yet for this patient, but I'm definitely going to treat the ocular surface, with the MGD and the SPK as well. And so this is a patient where I said to myself, there's a lot of SPK here. There is ocular surface disease present as well. but they're not complaining of anything. There's no burning, there's no irritation. And if you see 3 plus SPK on corneal staining, they're complaining of their vision, but they weren't complaining of discomfort. That raised a little bit of a red flag for me, saying, all right, we're going to pause anyways on doing any type of cataract surgery. I'm going to bring them back and do corneal sensitivity testing to make sure we rule out NK for this particular patient. And it was diminished. It wasn't absent, but it was definitely reduced. And so that would go into my clinical chart. And so for this patient, they probably had long-standing ocular surface disease NK, long-standing ocular surface disease dry eye, and now they have stage 1 NK. And I don't want to do cataract surgery on this patient. I don't care if they're getting a monofocal lens, if they're getting a light adjustable lens, if they're getting a diffractive lens, a multifocal, trifocal. We have to manage what's going on with the ocular surface before we move forward with doing their surgery. Here's the risk factors. It was a diabetic that was uncontrolled. The other comorbidities for this patient, ocular surface disease that hadn't been managed, the MGD, the staining, the inflammation is present. And so this was a patient that was ready for cataract surgery, but really important that we kind of think through the other things before we make that referral. This shouldn't even get to a surgeon. Don't send this to a surgeon. Manage that surface first. Get them to a point where you like the way that looks before they're sent off to see that patient. We know dry eye is common in cataract surgery patients. These are a couple different studies talking about that. The FACO study, where routine cataract patients came in, they were asymptomatic, and 50% of these patients had central corneal staining, and we need to rule NK out in those particular patients. Another study by Priya Gupta, the prevalence of ocular surface disease, they looked at osmolarity, they looked at MMP9, they looked at corneal staining, and they found out that 80% of these patients had at least one of those things wrong with their ocular surface, indicating ocular surface disease. Those patients should not be undergoing cataract surgery. So this patient, we did not end up doing synandromine. This was a patient that got autologous serum drops. We used a little corticosteroid as well because of possibly some inflammation there. Cleared up with those treatments. SPK is now clear, smooth. And now we'll get new measurements. We'll get new biometric readings. We'll get new topographies. We'll take a look at all of those things. And this patient is someone that we can very likely move forward with cataract surgery with. And so I think the important things here to keep in mind is these patients are walking into your clinic. And again, not always will you catch them right away, but just to keep these things in the back of your mind, hey, I can do a quick 5-second, 10-second corneal sensitivity test. It's not going to eat up a bunch of chair time. All right, I've ruled that out as a possibility. And now I can move forward with different treatment options that I have. So in conclusion, really tonight, and then we'll take some questions. The clinical history is key. I mentioned it earlier. You have it in your handout. Those key things in the etiology. I've never really diagnosed NK before without one of those particular etiologies that are present. When we think about corneal sensitivity testing, you got to do it. Do it if you suspect it. It takes 5 seconds. Do it the way that you want to do it, whether you want to get an automated technology or you want to use a cotton wisp. It's quick. It's easy to do. In my mind, stage 1 is just as concerning as stage 3 because it's going to progress. It's going to get worse. It's going to go from stage 1 to 2. And I'd love to prevent it from going to 2. And 2 is going to go to 3. And then just be aggressive. Treat them aggressively. Educate them on why you're doing it. Bring them back fairly often to celebrate the wins with your patient. It gains trust. It reinforces why you're doing what you're doing. So that's all I got tonight, but I will take some questions. I think we have a little bit of time, right, Ariel?
Yes, we sure do.
Perfect.
All right, let's get right into it. So the first question is, how cost effective is synandromine?
Yeah, it's a great question. So the company that produces synandromine has done really a wonderful job of making it available to us. I can transparently say I've never had a patient pay over $100 for the medication. Now, you have to, and I'll repeat it, you have to, number one, put the stage. You got to put the stage in there. And you have to corneal sensitivity test. If you don't have those 2 things in your chart, it will be an uphill battle to get it. But if you have those 2 things, it's been very successful for me. I've even used it in stage 1. I've had to fight a little harder for stage 1 just because, again, when you look at those clinical trials at stage 2 and 3, it's approved for stage 1, but insurance companies fight back a little bit more for stage one. So I honestly have had to get on the phone and do peer-to-peer reviews. I'll do that for my patients if I need to, if I really believe they need that medication. But from a cost-effective standpoint, I would reach out to the reps, to the company. They'll help you kind of navigate that. It's been, I believe in the data. It's been successful. I've used it enough, and you can get it for your patients.
Yeah, I've had the same experience. I have another question was if you've used synendriment, it's too late for me to pronounce that.
Yeah.
You did a beautiful job of it the entire presentation, along with an amniotic membrane at the same time.
Yeah, no, I don't typically do that. So I mentioned it, and I may have mentioned it very quickly. A lot of times, you're not going to get the Synendromin right away. You order it; it's usually, it's shipped to your patients, and so it's usually a month wait. Typically, I've seen it a little quicker than that. I'm placing that amniotic membrane graft the day that they're there, and I do that to start the healing process. The other thing about Synendromin that you need to know is if you've ever seen it, it comes in these kind of glass bottles. It's a very sticky substance. And so your patients, if they wear contact lenses, they can't put it in over their contact lenses because it'll just bind to the contact. And so the same thing would happen to the amniotic membrane graft. It'll just bind to the graft or to the ring, and it really won't probably get to where it's supposed to go. It's just the substance that it is. So no, I don't typically use it with AMGs,
Great.
or at the
And
same
then
time, I should
you
say.
mentioned
Sorry,
at the same
at
time.
the same time.
And then you mentioned a glaucoma pa patient in one of your cases where you took them off their glaucoma medications. Do you have concerns with them being off their glaucoma meds for 8 weeks if they're like moderate to severe glaucoma? Would you consider referring for MIGS beforehand?
Yeah, that's a wonderful question. I do. I do have more concerns if it's a moderate, especially severe patient. I'd look at their history, obviously. You would too. You'd look at their visual field, how significant is it, those types of things. The one thing usually in glaucoma we have in our favor is it is slow moving. Not always, but a majority of the time. And if it's a long-term patient of yours, you probably have a pretty good idea of how aggressive, the type of glaucoma it is. And so you need to make a judgment call there. One thing that you can consider, and we've done this in our practice quite often, is we'll do what we call a bimatoprost SR, which is a little implantable medication that goes inside the eye. And that's just, it can last up to a year. It can last longer than that. But I think of it more as a way to kind of buy me some time. And so if it is a more advanced patient that maybe you have on multiple medications, at least you have some medication inside the eye while you're treating the corneal condition. And so quite often we'll do that because then at least we know they're getting medication.
Hmm. Awesome. Um, let's see here. Do you find yourself often repeating the amniotic membrane placement, say that the first one improves it but has dissolved quickly?
I wouldn't say often. I'd be not transparent if I said I've never done that. I stick mainly to cryopreserved. That's for me. Nothing against dry membranes. It might be the type of corneas that I've seen. I've had more luck with cryopreserved. I see some tougher corneas, so I stick in that arena. And so I feel like it's less often where I'm having to replace it. I also think that you wouldn't be. There's nothing wrong with it if the cornea isn't healing the way you want it to, or it's getting better and you need another one, do it. Do it again. But I would say percentage wise, maybe 5% of the time where I have to use a second one back to back.
Okay, great. Oh, we have so many good questions. We'll have time for one more. There were a couple of questions on on how exactly insulin can help with NK.
Yeah, we're still trying to understand that. I put a little bit on the slide here. Um, you know, there's some, these certain receptors. I lost my, sorry, did that kick me off?
Oh no.
Might have kicked
Um,
me off. I can comment on that. Um, so you still hear me okay, Ariel?
yes.
Okay, perfect. So there's some insulin receptors in our cornea, and the thought is maybe that's what's creating some of the healing processes. Insulin-like growth factors, they're the insulin-like growth factor receptors. They're found in the cornea and the conjunctiva. And so if you put insulin on the eye, could that help with the healing? Again, not well understood. That's why we still consider it experimental. but that's really the belief around it.
Okay, awesome. Well, thank you so much for the amazing presentation as always. And we look forward to when we get to hear from you again on Woo You.
And if you have other questions, email me. I don't have my email on there. I don't have it, but I'm sure if you emailed someone, you could get my email address. I'm happy to answer them through email. Thanks for having me.
Cool. Thanks so much.
Appreciate it.